Hello and welcome to the Karmanos Advantage. I'm Guy Gordan. Good to have you with us. It is a heart-stopping diagnosis. Those three words, you have cancer. And we know that the fear that can come with that, the next question becomes, where do I go for treatment? Well, we're going to help you with the answer to that question today as we talk to a number of the fine professionals at the Karmanos Cancer Institute and also explain how their many satellites throughout the state of Michigan can mean that you receive this incredibly personal, highly evolved, multidisciplinary team approach backed by clinical research, all in your own community. I'll be joined by my first guest, the man that runs the show at the Karmanos Cancer Institute, right after this. Welcome back. I'm joined by Justin Klamerus, Dr. Justin Klamerus, who is president of the Karmanos Cancer Hospital Network and also the Barbara Ann Karmanos Cancer Institute. Welcome.
Thank you, Guy. Great to be with you.
All right, tell me about your empire, all these far-flung... I don't think really people have a sense of the scope of the Karmanos Cancer Institute's partnerships and what this partnership with McLaren means. So kind of give me an idea of how many satellites and how far flung?
We have 16 cancer centers that we operate in the state of Michigan, and we, if we go back to prior to the acquisition of Karmanos by McLaren, our reach only included Detroit and Farmington Hills. Those were our two locations. Now we go all the way up in the northern lower peninsula to Petoskey, Michigan, and that of course has a catchment area that draws patients from the eastern end of the upper peninsula, down into the central part of the state in Mount Pleasant, over to Lansing, communities surrounding Lansing, all the way in the eastern side of the lower peninsula to Port Huron, and then of course in the metropolitan area we have a number of locations in Pontiac, also Mount Clemens, and our facilities of course in Farmington Hills and Detroit.
So give me an idea of what that has done for those communities that may have had some talented oncologists like yourself when you were doing your fellowship in northern Michigan, but now you've got access to more than just maybe one oncologist.
For sure. Well, cancer is a heavy burden, and we all know the burden that cancer has on our society. And as cancer medicine gets so much more complex, we need a team of talent to help patients have their best chance and their best outcomes. And what we have seen and what we're most proud of is lifting the quality of care everywhere by bringing the talent that we have everywhere together.
The bottom line is, and I had a good friend that was an oncologist back in the early 80s in Grand Rapids. But now the idea of treating cancer has been so segmented and so specialized that no matter how talented they be, no one oncologist can really deliver that kind of care. Tell me, when we talk about a multidisciplinary approach, we'll do this in greater depth a little bit later on, but just give me a sense of how many layers there are to this.
For sure. So in medical oncology, which is my specialty, the chemotherapy part of treatment and really overseeing the general patient journey, we treat over 250 cancers. If you look at being a general medical oncologist, you have broad exposure to all of those types of cancer. What we have within the Karmanos program, anchored by our Comprehensive Cancer Center in Detroit, where our disease site subspecialists are, the people who understand and only treat lung cancer. We've connected them with our general oncologists that are, for instance, in Petoskey or in Lapeer, and they have access to multidisciplinary tumor boards, to clinical research, to care pathways and guidelines that we can lift and elevate the quality of care through that talent, through that reduction in variability in the ways things are done.
How much of has the role of technology played? I know what the drive is from here to Petoskey. It's roughly 3 hours, 25 minutes, whether I'm behaving or not when it comes to the speed limit. How much is that gap closed by technology now? How much does a doctor have the ability to almost be in Petoskey, even though they may physically be in Detroit?
Well, we're expanding that in many ways, not as fast as I'd like, to be quite honest. I think the technology applications in healthcare are challenging for all the safety concerns and considerations that we have to of course honor and respect. But for instance, in telemedicine, we're able to extend genetic counseling to any part of our network. We're able to offer phase 1 clinical trial consults, which are those first-in-human clinical trials. Right. We can do that through telemedicine to Petoskey to save that trip. And frankly, and as a provider who worked in Petoskey for many years, when patients are willing to make the trip, and many times do need to make the trip to Detroit, to our mothership here. However, when we use those technologies, we can identify patients that are appropriate to come and help do some of that discernment before they make the trip.
I don't want to get too far afield here, but can you foresee a day when one of your highly talented surgeons in Detroit can actually perform in Petoskey in real time?
Well, there are certainly technology applications that are employing that technology, and with robotic surgery, I think that is certainly possible. We're using it today in expertise in radiation oncology, where physicists, dosimetrists, the people who help to do the planning, the sophisticated planning that runs our radiation machines, experts in Flint or Detroit are consulting on cases around the state. So that's a different application, but already in place.
So when it comes to tumor mapping, you're already leveraging that to have all of those experts involved in the process.
We are.
So this is one of those wonderful questions. What does it mean when you're the #1 cancer center in Michigan? How do you get there, and how do people discriminate between #1 and #2? What would be the level or the difference in what's provided, and most importantly, the difference in outcomes?
Yeah, well, we're always proud of what we do, and we're proud of what we do because if you meet our team members, if you meet our physicians, doctors, nurses, and pharmacists, you'll see the difference that makes. In my view, you never arrive at #1. There's always continuous improvement that we have to do to be better. What it means in Michigan is we treat more patients than anyone else. We have access to more therapies than other cancer programs. At Karmanos, we test 50% of all new oncology drugs before they make it to patients and before they make it to market. And usually, patients who come into our network have access to those drugs anywhere from 1 to 2 years before other patients would. But I believe the commitment that anyone makes in cancer medicine is it's never enough. It's never enough.
This network approach, this multidisciplinary approach, you've been around long enough in the field to have seen the evolution of this. From a patient perspective, if I'm patient X, God forbid, how would I discern the difference as opposed to, well, I got my cancer, doc, back in the 80s or 90s to now?
Yeah. You know, I think two key areas. One is symptom control. If we look at cancers, fortunately we're detecting them and diagnosing them earlier than ever before, and that leads to a greater chance of cure. But we still have a lot of patients who are diagnosed with advanced stage diseases. And in those situations, we're much better at controlling symptoms. Pain, nausea, vomiting, the other challenges associated with advanced cancers. But then secondly, I have patients who write me letters every day telling me what it means to have a dozen people caring for them. And they feel it in a deep and intimate way. Their caregivers describe that experience. And so I believe we've gone from a day where cancer was in the shadows and never to be spoken of to the point now where we're making real headway with research. We are engaged as a community. We're committed to this cause. And I think our network definitely demonstrates that Karmanos now has a reach throughout the state of Michigan. And that's why we're here, is to help patients.
Culture matters. And one of the things that this oncologist that I was very close to, he would do rounds at 1 and 2 o'clock in the morning, that kind of person. When you have one person caring for you, I think there's a greater depth of the relationship. How do you make sure that the patient can still experience that, even though it may be spread among 12 or a dozen different specialists and providers?
I would hearken to, this is a calling for the work that people do in oncology. and those who are called get it. And there is an intimacy of this relationship that when I was choosing a specialty, I couldn't imagine anything that was more touching. And so I think people that go into this specialty understand and get that.
How many of your physicians have a more than a passing familiarity with cancer? How many of them are in this field because they had an up-close and personal experience either with a loved one, a mom, a dad, a sibling, something like that?
I think all of us. I moved back to Michigan from Baltimore, where I did my training because of an aunt who was dying of pancreas cancer in rural the Sault Ste. Marie in the Upper Peninsula of Michigan. She didn't have access to an oncologist. They only came once a week. So I was looking at my career and said, I want to be a part of making a difference for care here in the state of Michigan. And that was my motivation. But when we look at 1 in 3 women and 1 in 2 men facing a diagnosis in their lifetime, cancer is a disease of aging, and as we improve outcomes of heart disease and many other conditions, more people will get cancer, and it's an experience that's common and touches us all. And I think it's when we can connect to our own personal experiences, that makes us all the more compassionate and effective and better docs and treatment providers.
We're glad you came back home.
Well, thank you.
Dr. Klamerus, thanks so much. When we come back, we're going to be talking to one of the other doctors who would be at your bedside, who can explain in deeper detail the importance of the multidisciplinary approach that you will receive through Karmanos and McLaren. We'll be back. Welcome back to the Karmanos Network as we explore the power of the Karmanos Network and what the team concept brings to you if, heaven forbid, you should get a cancer diagnosis. I'm joined by Dr. Kiran Devisetty, who is Director of Radiation Oncology Research for Karmanos Cancer Institute. Doctor, hello.
Thank you.
So talk about the benefits of being part of a team approach at Karmanos.
So in cancer in general, you need a team and a highly expertise team in regards to the different ways we treat patients. Cancer patients in particular are never treated by just one physician. Often it requires a team of radiation oncologists, medical oncologists, surgical oncologists, all working together in concert to try to find the best care for our patient. Often, depending on the diagnosis, you need some sort of combination of chemotherapy, radiation, or surgery, and by having these physicians working together, we are able to figure out what's best for the patient.
Okay, there's that old adage that there are too many cooks in the kitchen. Mm-hmm. So in terms of coordinating care, mm-hmm. how do you go about doing that, and who in the hierarchy with all these different disciplines coming together has the ultimate authority, or is it a collective decision?
It is often a collective decision, and this decision is made in what we call our multidisciplinary tumor boards. Every one of our cancer sites has these tumor boards where all these physicians get together, not only the oncologists, but radiologists, physical therapy, pathologists, all these different doctors get together where we present every patient that has a new cancer diagnosis. We review the whole history, the imaging, the biopsies, and what else is required for the patient, and we speak together, decide together to figure out what's the best treatment for that individual patient. It does require intense coordination. One of the things I tell my patients is at different points in their care, there's going to be a different quarterback, and that quarterback will hand off the ball to the running back. And it's just dependent on what phase of their treatment they are in when that person is the quarterback.
Okay. So we've established that you may have a number of different quarterbacks on the field at any given time. Who ultimately is the coach?
The coach is a unified decision. Now, we do have cancer center directors that make sure our overall program is functioning in a way that provides the best care possible. But often we have individual oncologists that, if they tend to see the patient first, will try to direct the care, but it's always done in unison with other people. The best cancer care is coordinated care.
So what are the benefits to that as opposed to maybe designating one oncologist to be the chief of your case and then having them consult with others?
What I've learned in cancer care is there's never one way to treat any patient. It often requires a nuanced decision that relies on the experiences of all the different physicians being involved. When you have these multiple quarterbacks being involved, you're drawing from their experience in dealing with this cancer diagnosis and fine-tuning the treatments that we are recommending. So
give me for instance, an example, if you will, and I know there are all kinds of HIPAA regulations and things like that. So patient X, mm-hmm. give me an example that you've experienced where having that the different quarterbacks, that maybe someone with the run game had a great idea, but was when the guy with the better passing game came in and maybe saved the day.
So if you look at one of our most common cancer diagnoses we deal with in the network is breast cancer. And in breast cancer, there are many different ways we can approach someone. One of the more complex patients we have is patients who have a cancer in the breast and in their lymph nodes, which are located in the armpit. In certain situations, we may decide to do the surgery first, followed by chemotherapy and then radiation. Other times, we may do the chemotherapy first, followed by the surgery and then the radiation. And then if you do the chemotherapy first, that can change the way we do the surgery. So there is a lot of different ways we can go. And sometimes, recently, a patient came in where they wanted to do the chemotherapy first. And we asked, well, does doing the chemotherapy first necessarily change the surgery? And it did not. And for that patient, she appreciated having the surgery first, because in a lot of patients, they want to have that tumor removed as quick as possible. But there are other situations where there can be benefits to doing the chemotherapy first, and we have to educate the patients as such.
Or they think they can avoid surgery by having a successful chemotherapy.
That is correct. And that's often a big challenge we have to face in both the chemotherapy, surgery, and radiation portion. A lot of patients that I see, being a radiation oncologist, they've already gone through surgery and chemotherapy, and they naturally ask, well, if I've already had the surgery and the chemotherapy, why do I need to do the radiation? And it takes a lot of education for our patients to understand why.
Just out of curiosity, how passionate do some of these board meetings get? Because if you have different specialists with different philosophies, how do you come to an ultimate decision?
Passion is great. And
absolutely. If I'm the patient, I want everybody to be passionate.
Absolutely. You want to be passionate. And yes, there can be, quote unquote, many different ways to skin the cat. And when we work together, we start to appreciate each different point of view, and we learn from each other. I may come in with a certain opinion, but as I talk to my other physicians, they may say, well, these are the advantages or disadvantages of this approach. So long as you have a receptive audience and that they are interested in learning and trying to find out what's best for the patient, we often can come to a consensus decision.
In terms of, many of us look at the Karmanos Institute and think of it as a treatment center, but it's much more than that. It is also a center for a lot of clinical research. How is that brought to bear, whatever the discipline may be?
So I'm particularly in charge of radiation oncology research, and one of the big things in Karmanos in general is trying to be involved in transformative cancer care. And the way we do that is through clinical trials. And with our main downtown hub, we have been able to disseminate a very large number of clinical trials throughout our network sites, making these clinical trials available to patients throughout the state. And patients in particular get interested in clinical trials and excited about clinical trials because we're bringing tomorrow's treatment to today for them.
Well, nobody wants to have out-of-date treatment, right? But we often see, and again, this is for my curiosity, sometimes conflicting research. You can have something that a study that might confirm what we knew earlier. It might conflict with it, but do you change established protocols based on one study? So how do you sort through that as you determine what the best course of action is for a patient?
It's not often one study that will dictate a change in treatment. It's often an accumulation of studies. In science in general, if we have one study that demonstrates one benefit, we often have confirmation studies to verify that benefit. As we build up this story in regards to getting all these patients on clinical trials, eventually our guidelines will change to adopt that. We want to practice medicine responsibly, but we also want to take the best of what we have and make it better. And the way we do that is through clinical trials.
Give me an example of some of the breakthroughs or developments through clinical research in the past few years that you have found particularly dramatic or that may have profoundly impacted the course of action on a patient that made a great deal of difference.
So one of the most difficult patients we deal with is when cancer has spread to the brain, something we call brain metastases.
Right.
And often in that situation, we have to do what's called whole brain radiation. Now, unfortunately, when we do this whole brain radiation, there can be some long-term effects, often with their memory. And so we recently had a clinical trial open where it looked at different techniques in regards to sparing the memory of these patients. If we spare the memory of these patients, it can translate to an improved quality of life. So we did a clinical trial looking at the standard treatment versus the memory-sparing treatment and found the memory-sparing treatment was leading to better preservation of memory, thereby improving the quality of life in a very difficult situation.
Right.
And this is something that has changed the standard of care.
From the standpoint of a physician practicing at Karmanos, talk to me about the trickle down of the clinical research being done there to the facilities that are out county and throughout the state that are part of the network. How quickly does that happen? We know that communication in any organization is key. But when you have something that is going to change the way things have been done, just by their very nature, sometimes you get resistance. So how fast does it trickle down, and how powerful is that in terms of sending that out into the various satellites?
That goes to leadership and culture. When you have a leadership at the top that is vested purely in trying to make sure medicine gets better and in clinical trials, that trickles down to the rest of the institutions. Once you have that good leadership, strong leadership, and have that culture that is already established in that downtown hub, you find the right people to translate that culture over. And so that was one of the roles I played within our system, trying to bring that culture, establish that infrastructure, and get the buy-in from the top down. It's never one person that can make a program succeed. It's the whole team that you assemble. And when you bring in this excitement, you bring in this energy, you bring in these ideas, and you say, this is for the patients. This is for making medicine better. And when you lead by example, it eventually brings everybody in.
And so you break down the silos and the culture that said, but we haven't done it that way before.
And that's naturally resistance, not just in medicine and everything in general. In Karmanos in general, when we implemented this clinical trial system, within 1 year, just 1 year, we became top 5 in the country in certain types of radiation accruals. And that was within a network community-based setting. And we've set the example for many other institutions and systems to look at how we've succeeded in that way.
And results are what matters.
Absolutely.
Dr. Devisetty, thank you so much. And we will be back with more as we explore why you have a network advantage and the power of that network. The Karmanos Advantage, next on WJR. Welcome back to the Karmanos Advantage. I'm Guy Gordan, and we're exploring the power of dealing in a network and the power of teamwork. We probably beat the football metaphor to death in an earlier segment, but it does hold here that you will have a number of quarterbacks, highly talented Mahomes kind of quarterbacks in your care when you are treated by the Karmanos Cancer Institute. And that's true whether you're dealing with the center in Detroit or in one of the satellite centers throughout the McLaren Health Network. And their partnership, this incredibly unique and powerful partnership with the Karmanos Cancer Institute. Dr. Devisetty is still with us. You met him in our earlier segment. And we're joined by two people that are really in the trenches when it comes to clinical research. This is one of the most powerful aspects of dealing with Karmanos. I'm joined by Jaclyn Ventimigli, who is works in the clinical research sphere as a coordinator or supervisor of clinical research, and Delaney Erickson, clinical research coordinator within that network. Welcome to you both.
Thank you for having us.
Talk to me about the dealings with patients when it comes to clinical research. Very often, these are people that are, their cancer may be unique. They may be, I wouldn't want to say desperate, but certainly desirous of the latest and greatest they can bring. Tell me about the mindset that they bring to it and how you respond to that.
Well, we're very lucky to have motivated physicians who are very educated on the clinical trials that we offer, and they are great advocates for their patients. So that is the patient's first step when coming into, is interested in learning about clinical trials. That physician really can provide a lot of insight, and that just kind of starts the team approach that Dr. Devisetty spoke about.
And Delaney, from your end, how do you coordinate that, and what kind of resources are brought to bear?
So from our end, I will get in daily life an email from Dr. Devisetty. I have a new patient. They seem good for this trial, and that's when it all begins. We will have a very good system where Dr. Devisetty and the NPs and the nurses can scan in documents to us, and we share the information. We're able to review the ICF for the trial, the informed consent, and then we just proceed with reading through their medical history and seeing if they're appropriate to fit onto the clinical trial.
Dr. Devisetty, what makes a good candidate for this kind of clinical research? Because I would imagine everybody wants to be part of something like that, or at least most people.
Most people do. In my personal experience dealing with patients, when you mention the idea of a clinical trial, they often get excited. One thing I do with my patients is I talk about the history of how clinical trials brought us to where we are today, and when they have the opportunity to participate in helping the future patients, they get very excited about being part of something bigger than themselves. While we are helping them, they are helping future patients. Often the excitement of the entire team is almost infectious, and when you have this team that's excited about clinical trials, the patient often gets excited as well. not only in regards to getting access to, again, to tomorrow's treatments that we can bring to today, but just being part of something bigger.
Okay, in terms of managing expectations, who might not be a good candidate for a clinical research?
So this is one of the challenges we have in clinical trials in general. Whenever we have a clinical trial, there's often strict criteria that allow a patient to be quote-unquote eligible onto that trial or not. So not every patient will be eligible for a specific clinical trial. But what we try to do at Karmanos is to have a good portfolio, a broad portfolio of trials that gives the most access possible to our patients throughout the network. And by having this broad portfolio, we are getting more and more patients onto clinical trials.
Delaney, as you're breaking down who is eligible and who isn't, how microscopic do you go in terms of the data that you look at this? Because now we know that there are clinical trials which a simple change in a DNA code could be the difference as to whether you're eligible or not.
Yeah, I mean, wow. We go into a lot of depth when we're reading through the medical history. You have to make sure that the patient fits that criteria to a T, because something as like a heart attack that happened 30 years ago may not clinically matter right now to Dr. Devisetty, for example. However, if the trial would exclude that, it is my job to, sift through those records, find that, let Dr. Devisetty know this was found in the record from 30 years ago, and yes, unfortunately, it does make them ineligible for trial.
So you may appear to be a great candidate, but as you're also trying to manage the controllable variables, that may exclude you. Jaclyn, in terms of, talk to me more about the kind of patients that you interact with, and this, I guess you would call it the zone of uncertainty, that they're not quite sure what they're facing, and how the clinical research can kind of help with them with peace of mind.
So luckily, going back to that team approach, we have research nurses that work at each of the network sites and downtown who are our experts in our face-to-face contact with our patients. So they are the ones who are also advocating for these patients on these clinical trials and providing that support to the physicians. So they really are, they're looking at the eligibility criteria with us as coordinators who are located, like Dr. Devisetty said, we're centralized downtown. So we're having phone calls with these research nurses each day to talk about patients that could potentially be eligible and whether or not they meet this criteria. So even though the clinical trials coordinators do not have face-to-face contact with these patients, we're really on the back end looking at all of their medical history, like Delaney said, to see if they're eligible with the research nurses who are the ones communicating this information directly to those patients. Right.
And how much does the peace of mind and state of mind of the patient go into whether or not they're suitable?
Oh, I think it's huge. If we are, their mindset is, I think, makes up for, how compliant they'll be on these clinical trials. So we really need patients who are motivated to, clinical trials can often require so much, I would say most of the time, for patients. Visits, maybe weekly, a few times a week.
They're under greater scrutiny.
Absolutely. And so you need a patient to really, like Dr. Devisetty said, really be motivated to want to participate in this for themselves and for science.
And to that end, Doctor, from a resources standpoint, does it matter whether the patient is coming here from, let's say, Roscommon, or whether they're based here in Detroit in terms of the kind of resources that they have access to?
So the Karmanos mission is to make these clinical trials available at all 16 of our cancer centers. And we've invested significant resources into our infrastructure and staffing to provide that advantage at a local level. And are there certain clinical trials that are just uniquely available in Detroit? Absolutely. But we still try to expand that portfolio as much as possible to our network sites. And that led to the high rates of accruals I was talking about earlier. Clinical trials are not easy. First and foremost, it requires experience, it requires dedication, and that's the Karmanos Advantage. They started at the beginning being aggressive with building an infrastructure and a culture to promote clinical trials, and we've had that disseminated throughout all 16 of our cancer centers, which is why we get so many patients on trial.
In terms of the demands on any patient for any treatment or something that involves a clinical trial, how much of this has to be done face-to-face, and how much of it, from a convenience standpoint, especially if they're a patient from outstate, must be done face-to-face? Or is there a telehealth application here. Talk to me about that.
So we haven't seen telehealth come into clinical trials yet, but I do think that that is the way that we're going. I think that we are seeing patients come, even from out-of-state patients are coming, being referred to Karmanos for specific clinical trials. So I think with that, telehealth is definitely, it's inevitable that it'll work its way into clinical trials. There's just a component of making sure that we have the right regulatory approval to do so.
We've actually already been very successful with telehealth when it comes to our genetic counseling. A lot of these patients have family histories with strong history of cancer diagnosis. We have an excellent genetic counseling department that's based in Detroit, but we do telehealth from multiple of our network sites to meet with them so they don't have to drive to Detroit for it. So that model is there, and it will make its way into our clinical trials program as well.
And what will that to provide from a patient focused standpoint?
So it's ease of convenience. We understand these patients are already going through so much. And if we are able to implement this telehealth program and we are able to do it more locally, it's easier for them to get through their care and deal with the often effects of treatment that come with treatment.
Dr. Devisetty, Jaclyn Ventimigli, and Delaney Erickson, thanks to all three of you.
Thank you.
Thank you.
Welcome back to the Karmanos Advantage. I'm Guy Gordan as we explore the power of the network, the appropriateness and the power of teamwork, but also the soft skills, the human skills that Karmanos brings to every patient that comes in the door, whether it may be in Detroit or any one of the far-flung satellites within the McLaren Network, which partners with Karmanos. I'm joined by Danyelle Howland, who is a nurse practitioner at the Karmanos Cancer Institute at the McLaren Oakland Lapeer. So you're up in the Thumb area.
Yes, I am.
Or headed in that direction. Wait,
Yes.
Talk to me about that first time that you meet a patient and what their mindset is.
I think the big thing is they're scared, of course, and we often have patients question our ability to take care of them up in the rural areas or out in the network. So it takes some trust building, relationship building, so they feel comfortable with us.
Because their idea is, I probably should be at the mothership.
Exactly.
Not an outpost.
Exactly.
Yeah. And so how do you convince them?
So usually, when you first have your first couple of meetings with the patient, we reiterate that everything that we do at our network facility, they could have done at a bigger center too, or downtown at Karmanos. So I think that, like I said, the trust that we can do everything that the other centers can do is helpful.
Well, what was the old song, anything you can do, I can do better?
Correct.
Or at least close to equivalency is what we strive for, right? So when we talk about the multidisciplinary approach, from a nurse practitioner standpoint, since you are the one with the most immediate contact with a patient, how does that manifest itself? How do you see it work?
It's a really nice. The patients enjoy or are appreciative of all these experts making decisions for them. So I'm sort of the missing link to all of that. So I sort of, explain what every aspect of that multidisciplinary approach means to them and what each doctor would provide, what care they provide. So it helps them feel a little bit better about somebody. You have many people overseeing you, not just one.
Yeah. And what does that do to their mindset compared to when they first enter the door and after they have this experience of seeing multiple experts, all star quarterbacks coming in the door?
So it makes them much more comfortable with our out centers or out networks, clinics, that they know that they're going to be well taken care of, and we're going to, have the top experts and the top medicine to take care of them right there in their hometown.
And it's not just about dealing with the patient. You've also got the patient's family there, the patient's spouse. Sometimes they may be more, I don't want to use the term aggressive, but they may be more assertive than the patient is because bearing under the strain of the disease, they'll have advocates there for them. How do you negotiate that?
That's difficult, especially with Dr. Internet is very, very is challenging for us.
I Googled this, and this is what Dr. Google says.
Right, and if you Google or anything, any kind of cancer diagnosis, you're going to get one of those big centers in the country. Our care and just our clinics alone, it speaks volumes for how we take care of everybody.
And how important is that confidence factor?
Very important. Very important. This is, life or death for them. So they expect us to take, control of their care and give them the best outcome that we can.
And just from, you've got kind of the best front row seat that there is to watching all of this come together. How does that confidence in care and a multidisciplinary approach lead to better outcomes? What's the effect on the outcomes?
I believe the outcome is much, much better when we have these local clinics taking care of our patients. I believe they have, all of our experts there are invested in the community too. So we take pride in what we do. And it's about relationship building too. When those patients come in the door, we, know everything about them down to like their last vacation and their family dog's name.
Right.
So that's a big deal. We're family to them. So they get used to seeing us on a weekly or daily basis.
The fact that they can receive this incredibly powerful treatment closer to home, closer to loved ones, closer to their support system, both social, faith-based, and otherwise. How important is that they can gain the same resources and access to the same resources they might in Detroit at the mothership,
yes,
but they get to do it pretty close to home.
Right, and we're the only cancer center in the county, which, and our McLaren is the only hospital in the county. So it's very, very important for them to be able to drive, 5 or 10 miles to treatment. And we have a lot of elderly in our community that we treat that just would rather not drive down
Sure.
here. So a few miles from home is good.
Well, and do you find that because they're closer to home that having that easy access to their family support makes a difference?
Definitely, because they can always have people that can, that are able to visit during a treatment, or they can have as many people as they want come to doctor visits.
How is this network approach different than what you've seen in other experiences?
I think the network, you're typically going to have the same practitioners all the time. So like I said, it's that relationship building that you would get. So you may have the same, 3 or 4 nurses in the infusion room every time you come. So they become family to us. So I think the network keeps us close. And
what about the other services beyond medicine that you can provide to patients in that setting?
Definitely social work, any kind of psychological, social psycho help, dietary needs. We have all that in our clinic.
All right. Danyelle, continued success in everything that you're doing on behalf of your patients and on behalf of Karmanos.
Thank you.
Danyelle Howland. And that will do it for this edition of the Karmanos Advantage. We thank you for being with us. And remember, if you want to learn more and do your own research, you can do that by calling 1-800-KARMANOS. That's 1-800-527-6266. Or on the web at karmanos.org. I'm Guy Gordan. Thanks for joining us.